Hi, welcome everyone to another session of Navigating a Crisis, Conversations of Change. And this one is happening, as you can tell, a bit later in the afternoon. Things are a bit dimmer than they usually are. But I have with me today Peter Higgs, who will be joining us in conversation. But before we start that, I would just like to acknowledge the traditional custodians of the land on which we're meeting, and also where you might be viewing this from, and pay respects to elders past, present and emerging. I will let Peter introduce himself because he can probably do a better job than me. We can get into the questions.
Great. Thanks a lot, Naomi. And thanks for the welcome. My name, as Naomi said, is Peter Higgs. I teach public health at Trobe University. I'm in the public health department there as an associate professor, and I basically have a fairly active research role in and around Melbourne street drug markets. I work a lot with people who inject drugs. So that's kind of the focus, I guess, that where I bring my alcohol and drugs kind of perspective from is the basis of my research. And I teach a subject on drugs and addiction out at La Trobe.
Amazing. Thanks, Peter. So you have hopefully some interesting perspectives to bring to this, but the point of these conversations is for people to be able to share their experiences at this point in time, and other people to learn from that, other people to see the the human experience in it, which often we're just seeing policies or organizational positions. So it's the human through that, and hopefully to learn from each other as well. So. Sure. The first question I have is, what are you currently doing for yourself, your staff, or perhaps your students, the people that you serve, and I guess the organisation more broadly, how to manage the situation in a way that's safe, in a way that's humane, and also in a way that kind of maintains a sense of dignity for people, because agency's been taken away. So it's how do we create spaces that are safe?
It's quite crazy. I mean, at the university, basically, this is my 6th week of working from home. So I've been off. We're essentially locked off campus since the 16th of March. And for my students, that means that we're having to do all of our lecturing or all of our class time over the internet, which is less than satisfying for me, I must admit. Is so much more engaging having that opportunity to work face-to-face with people. And I mean, to be honest, you probably have to be a hell of a lot more prepared to teach online in the online space, and especially not having prepared a lot to run the classes for that. So this semester, I'm teaching a qualitative research method subject for the Masters of Public Health students. So it's a pretty basic introduction to qualitative methods for students who are especially interested in doing qualitative work for their minor thesis. And I've been really fortunate this semester to pick up 3 students doing qualitative work. And what that would normally look like in a pre-COVID sort of space is that they would have opportunities to come out into the field and to be part of some of the work that I'm doing longitudinally with people who use drugs. So the main kind of, I guess, the base I use is a lot of the work that I do is a cohort studies called Supermix. It's run by Professor Paul Dietz at the Burnett Institute, and it's a cohort that's been running since about 2008 and was refunded at the end of last year, and we spent end of the year before last, so it's been refunded for another 12 months.
What is today?
I know, exactly.
It's elastic right now.
And over the last 12 months, we've recruited an extra 500 people into that cohort. So it's sitting at about 1,300 now. And we partly did that to be able to over-recruit in Richmond as part of the Safe Injecting Facility, and as being able to have, I guess, a group of people that we could use to help evaluate that service. Not formally, because it's not part of the formal evaluation, but having participants in our study who are also using that service means that we can compare them to other people in the study who aren't using the service, and we can work out what kind of a population that is. But anyway, so the cohort essentially, if the students in a normal world would have been coming out into some field spaces like Richmond or Footscray, Frankston to do that work, we've moved and we've been online doing all of our interviews now online for the last 4 weeks. So we started that process, which, to be honest, would be really difficult if you didn't have those relationships with people already. So the participants are pretty used to us calling them and saying, you're due for an interview. Normally that would mean come and visit us in our mobile van or whatever. But now it means we're not doing that. We're just doing our interviews over the phone, FaceTime. I haven't done any over Zoom. I'm not sure if anyone else has done one over Zoom, but we do have that. We had to amend our ethics to get. So there was all kinds of things that meant that we had to respond really quickly in this space to change the sorts of things that we were doing. But yeah, so I've got 3 students who are going to be working with me over the rest of the year now as part of the cohort. One who's going to particularly focus on COVID-19 and look at access to sterile injecting equipment and how that's changed in relation to COVID-19. One who's going to be doing some work on just interviews with people around that program that the Department of Corrections fund on methadone in that first month when you get out of prison. So wondering how that sort of situation is responded to by participants. And the third one is looking at participants in our cohort who've never overdosed. So only one of the 3 is kind of directly going to be looking at COVID stuff, but we imagine that COVID will have quite a big impact just because of the way in which we'll be collecting data over the next, we imagine 6 months at least will be done over the phone. So yeah, so that's what that's kind of meant for me. I'm working from home mostly in my house with a year 12 daughter and a first year uni son, and my partner's a GP who's still going to work. So she's got some semblance of normality to her life. Doing a lot of telehealth and quite a bit of drug and alcohol work as well. But yeah, I'm essentially just upstairs in the study.
And that's the things, isn't it? It's a lot of people have spoken about young children having to manage young children.
Oh gosh,
but I can even, I suspect you obviously have an upstairs, which suggests there's a downstairs as well. But a lot of people who are living in houses where they're trying to find space for 2 working parents, 3 high school, uni age, everyone trying to use the internet at the same time. Like, it's a bit of a nightmare.
I know.
I had a couple of questions just to ask about what you've shared. And one of it was just around, I think you've hit on a pretty key point where a lot of practitioners are engaging with people over the phone and finding that they don't already have an existing relationship, that it is really tricky, and it is really the things that you would normally ask or be shared or disclosed is really different. And sometimes it's more, sometimes it's less, depending on the person. So I was just wondering how you found that. I mean, because you don't normally talk to them over the phone, do you? You would normally meet them in person.
No, we talk to them over the phone, but it's not for the interview. We normally do our interviews face to face. So we do have quite a lot of phone engagement. We've actually found Facebook amazing. Just messaging people through Facebook. And to be honest, we've probably had a lot more time to try and find people that we'd lost to follow up as well. So as you can imagine, with a group like this, over 10 years, you do lose track of people. And I interviewed a guy the other day who he'd been seen 12 months ago, but he hadn't been seen for 8 years before that. And he'd moved down to Geelong and was working on fishing trawling and doing stuff like that. So that we'd kind of lost contact with him. He'd kind of managed to find him through Facebook, I think, and then re-engaged. And I spoke to him last week, and he's not been working for the last 3 weeks. So as part of COVID, they're just not doing as much trawling as they used to, apparently. So
not doing much anything as we used to.
And so it's been, because he's had a relationship with the organisation, even though I'd never met him before, that wasn't so difficult. I think that just being able to engage with people who know about the study and what they're in for, in a sense. But I think it will be a lot trickier for people who are trying to talk to people that they don't kind of know, and especially if you're not able to see them, you have no kind of context at all. It must be just
really tricky. Yeah. It's really tricky. But I think some of the other things that people have been finding, or certainly anecdotally been finding, that corrections clients or forensic clients are engaging a lot more than usual. So, and the other element is also, like, a lot of NSP programs are still running really well and are very popular with people, finding lots of different ways of being able to service people. So it'll be interesting to see, from the findings from this, whether that's in your populations as well, or the populations you work with.
Absolutely. I mean, certainly. People haven't, in the interviews, we've been interested around access to sterile injecting equipment, obviously, and as you say, those services have been doing an amazing job. They haven't really limited. They've thought really creatively around how they can access people, and we've heard of some people having stuff mailed to them, and those sorts of things. So
there's a click and collect model running as well, where people call up and order it, and then come and pick it up, and home drop-offs and all sorts of stuff. So I think even with some of that, if there's other things that people require as well, they've been doing a bit more of a drop-off. So they might have stopped a big supplies that people require too. So it's amazing to see what people are able to do. Great. Thank you for that. And then the second question, which could be helpful for you, is how can people support you in what you're doing? And the idea around this was, if people are feeling that they don't have as much agency perhaps as they normally would, or not able to contribute in the way that they could pre-COVID, is there anything that would help your research, or help what you're doing in terms of advocacy or support or resources or volunteers or?
We've had to change the way we kind of engage as a team, I think. So we've set up extra communication stuff. So we're using Slack, and we're using Google Hangouts, and we're using a lot more of that than we would have normally as a group of field workers, because there's about 9 people who work on that team at the Burnett across a range of different studies. And I think they've, really spent a lot of time thinking about trying to keep engaged, because it's been hard for everyone, I think. And they've also introduced a kind of an 80% rule, where the expectation is that you're probably only operating at 80% capacity, and that, if you're putting in a 6-hour day, then, that don't feel hard about on yourself and that sort of stuff. So be kind to your own self stuff, and reminding each other. We're having a reasonably regular log-in with some experts on COVID as well, around what's happening nationally. So we've got people at the Burnett who are involved in a range of different studies, and at La Trobe who are in at the Department of Human Services, who are able to give us kind of, on the spot
insider information.
Exactly. All of that, how it's kind of going, and that you feel like you're kind of a part of it in a way. It's you're not too distant. So I'd hate to think what it's like for coffee shop owners or all of that, who really just must feel like they don't have any sense as to how this kind of decisions are made, and what kind of, social distancing means, and what impact it's really had on being able to, limit the spread of the virus and those sorts of things. So I think, public health's really come onto its own. If we don't get a lot more students out of this, God, there's nothing else that we can kind of do like this in a way.
That was what I thought, Peter, when we're finding people to interview and have conversations with, and I'm like, we have to talk to an epidemiologist. We have to. It's their time to shine. It's like, this is where they're so. And I think, obviously, apart from the, being grateful to still be employed in terms of the financial side of that, but I think it's, it's grateful. There's a sense of gratitude around having something, a purpose and meaning, and there's an opportunity to contribute to it, which, makes it really difficult if you don't have that.
And it's been interesting just having a teaching sort of role as well, is you realise how vulnerable a whole bunch of students are, and living in share houses and that stuff, but without access to internet and space, and people working in their backyards, and all kinds of really complex things that when you're on campus you don't have to think about those sorts of things. And I think La Trobe's been pretty proactive in trying to offer support in terms of finances to students who are struggling, and
that's great.
They've put some things in place, and trying to roll that out, but it is very tough, and the international students situation is it must just be so complex for a number of them in terms of, you know, being told on one hand they should just go home, and
Yep.
on, you know, what are you going home to? And
Correct.
you know,
Yeah.
yeah, I wouldn't be going anywhere out of Australia or New Zealand if I could avoid it, you know, in terms of when you look at the numbers and how other countries are approaching the problem.
Yeah.
It's just phenomenal. Yeah.
Yeah, absolutely. And it's great to hear that the university is doing a lot to support students, because that was definitely a key issue, not just in terms of living spaces, but for me more so was thinking about international students, and you know, they're not able to get benefits, they're not able to go home,
Exactly.
and they're not able
they
to.
could be doing a hell of a lot more. I saw that, you know, the South Australian government has been very proactive in trying to put things in place, and there is, I think, City of Melbourne also had some particular schemes that they were trying to look at to support international students, which not all of the ones at La Trobe obviously live in the city, but it's, yeah. I think there's still a group that is pretty vulnerable in this whole thing, but they're probably nowhere near as vulnerable as most of the people that we're working with in this kind of context either.
Oh, absolutely. Yeah. And I think one thing, you know, that this has done, to my mind anyways, is exposed a lot. You know, it's exposed a lot of the flaws. It's exposed a lot of the issues, the gaps, you know, the things that we, you know, perhaps thought were working okay, but it's certainly opened up a whole new perspective and a lot of issues for people, which, you know, is a good thing because it's brought stuff to light. Yeah. Cool. Okay. And then the final question is around what is your, and I'm sure you do, your positive reframe for how this, you know, notwithstanding obviously the great harm that it has also caused, and, you know, financial distress, physical death, you know, a range of other things, separations. But what do you see as some of the, I guess, the opportunities that this has potentially created for not just individuals or our sector, but also just the collective?
Yeah. I mean, one of the things that I've really thought about is the need for treatment to reorient itself and to think a bit more creatively about how it does engage with people. And there's been some really great responses, you know, in terms of thinking about different ways in which pharmacotherapy can be offered. You know, a month of takeaway for people who are stable on Suboxone, or weekly takeaways for methadone, those sorts of things, which I hope means that clinicians as well as the users of those services can kind of get their heads around and help navigate beyond the end of this. I don't know when, but hopefully the start of next year at the latest. But I just think that it has provided a range of an opportunity for people to take a step back and think, well, what do they actually want to be doing, and to think about how we can do that in a better way. It seemed, I mean, when I was kind of imagining it, it seemed to be taking a long time, but I think the department has responded fairly well to those changes in terms of thinking about how, you know, we need to be offering OST in a different sort of way that is more client-centred and enables them to maintain social distancing and all of the other stuff that's kind of going on. Because, I think explaining that to people is difficult.
Yeah, but it's so, I think, because this has touched everybody in a very similar way, obviously to different extremes, but you're able to actually understand other people's perspectives a lot easier because has been stripped away. So,
I mean, I've seen stuff in the press. I haven't seen how it's working in practice, but certainly in relation to, you know, people being able to start on methadone just by going to the chemist without actually necessarily needing to go and see a clinician, a drug and alcohol specialist in that way. Safe supply, as they're doing in Vancouver, that people are probably aware of in terms of trying to get, you know, access to opiates that mean that people aren't relying on fentanyl, which has been such a traumatic experience for so many people in North America. And I think, you know, having those opportunities to spend some time evaluating how those programs have gone will be really interesting. We were touching on earlier in terms of the homelessness stuff and how, you know, being able to provide housing for people in those situations, which is, you know, giving them some autonomy over what that sort of looks like beyond the 1 month period or whatever they are getting at the moment. And those sorts of things will be really interesting as well. I'm fairly optimistic that we can try and keep a number of those programs running that are focused on, you know, providing better services for people.
Absolutely, absolutely, and that idea that, you know, we've had a testing ground for it. You know, it's not just in theory; it's we
exactly
genuinely demonstrate the benefits for a range of different ways. And that's certainly where the sector is kind of looking now, is how do we hold on to the things that we know that are working? How do we, you know, integrate some of these new innovations into our practice and into our agencies and into our funding, so it can be sustained moving forward. I think I just used 3 buzzwords in one sentence then. That's really bad. I should I could have used pivot. I didn't use pivot though. I could have great. I knew you'd have a positive reframe finish up, but I think, you know, there has been lots that's changed for the sector, and mainly for the better from what I can see. So Excellent. So thank you so much for your time, Peter. Is there, I'll talk to you afterwards about whether there's some way that people can potentially contact you if they have any questions or they want to know more about them.
Yeah, I'm pretty easy to find. Just type me into Google. I think I turn up.
That's how I found you.
Exactly.
It works, people. But it's been a real pleasure. So thank you so much.
Thank you very much. See you, Naomi.
Ciao.